Welcome to Health Strategy TV. Today I'm joined by the Right Honourable Stephen Dorrell, who is Chair of the Health Select Committee, here to talk about the Health and Social Care Bill. Welcome, Stephen.
Thank you.
The Health and Social Care Act has recently been passed by Parliament. PCTs will soon disappear. Clinical commissioning groups will take on their full range of responsibilities. Is that the light at the end of the tunnel, or is it a train coming in the other direction?
I don't think in truth that it's either. I think it's an evolution of a commissioning process that was first introduced into the health service 22 years ago. And I think the important change in the new name is that there will be more clinical engagement in the commissioning process, so that the key decisions about the shaping of healthcare for the future will no longer be just managers, but it'll be a management process with an important clinical input and accountability. And I think that is important because clinicians are in the end the people who deliver care, and they are the people who understand best how to meet the needs of individual groups of patients. So engaging them in decisions about how care is delivered does seem to me to be good management, but it's a relatively modest step in a very familiar landscape.
Have clinicians got the necessary commissioning skills to take on a whole different scale of commissioning responsibility and budget handling?
Well, with respect, I don't think they're being asked to do that. I think they're being asked to contribute their clinical know-how to the shaping of services for the future in order to ensure that the services for the future reflect more accurately than they have done in the past best clinical practice, that clinical practices are challenged, that we do deliver care that reflects best modern standards and quality. That's the clinical input. Nobody is expecting doctors to become managers of the system unless they wish to become managers. There's always been some doctors who've become salaried managers. They make an important contribution, but that's a very different thing from the practicing doctor feeling, and nurse and other clinician, feeling that they have the opportunity to contribute to the commissioning process.
So who will hold the accountability for ensuring that budgets balance at the end of the year?
Well, the answer is that the management structure accountable in each CCG to the commissioner, the members of the commissioning board. And of course, each CCG is itself responsible to the National Commissioning Board, because this is taxpayer money, and every taxpayer, never mind every patient, would expect it to pass normal standards of public accountability.
But it is doctors who will be the bulk of the makeup of the boards, isn't it?
No, that's true. There will be clinicians, actually, doctors, including other forms of clinician as well. But the day-to-day management of the functions of the commissioning group will be handled by management and supporting staff, as has been the case for the 22 years that we've had a commissioning process in the health service.
And we've seen those managers are primarily working within primary care trusts at the moment. But the primary care trusts have lost a lot of very good people in the run-up to the changes. Have you got the confidence that there is sufficient expertise left within the remaining PCTs to actually carry that task forward now?
Well, I agree that there's been considerable turbulence and unhappiness in the PCT communities, and indeed that there is a commitment, which was incidentally inherited from the previous government, to reduce the scale of resource committed to supporting commissioners, whether they be PCTs or CCGs. Using resource more efficiently is not something any government, or indeed any member or supporting staff member of a CCG should be apologetic about. We need to ensure that the CCGs going forward focus on where there's real value to be added in the system through the commissioning process. And that, for me, is thinking forward about how care can be best delivered to meet the economic and quality challenges that I've been talking about this morning. The requirement to deliver, to meet rising demand out of a budget that won't grow as quickly, and to ensure that we deliver care that is more joined up from the point of view of the individual patient than has been the case traditionally in our system.
Stephen Dorrell, thank you very much indeed for your time.